want to, you can turn your camera off, but just a reminder that we are recording today. So secondly, we have muted everybody. And so we've done this intentionally with this platform. We'll give you a chance at the end during the question and answer to unmute, to ask your questions live if you would like. But I think this will just help with distractions today. So that's the first thing. The next thing is there is a chat function in Lifesize, and you can get to it on the right side of your screen. There looks like two little text boxes. And I think there's a number 1 beside mine. So if you want to chat into the chat box, if you want to put your questions in there, we will be tracking those today. So we will make sure that those are provided to Pat at the end during the question and answer period. So please feel free to do that, and we will moderate that. There is also a hands up feature, which I will remind you about later. We won't be using that until after the presentation and during the question and answer period. So we'll remind you again about that afterwards. Kate, just before I start, is there anything else, any tech issues that I missed here?
I don't think so. If anyone has any issues at all, if you put them in the chat, there's going to be 2 individuals monitoring that. So that would be your best place for any sort of tech questions throughout the meeting.
Perfect. Great suggestion. Okay, so it's my pleasure today to get started by introducing the Dean of the Faculty of Applied Health Sciences at Brock University. So Dean Peter Titus is going to start with some introductory remarks.
I have to unmute myself, so here I am. Thanks, Dr. Gardner, and welcome to the first Master of Applied Gerontology Reimagining Aging Speaker Series, and one which we expect will be the first of many such events. This Master of Applied Gerontology program is truly a community-oriented and practical graduate education program that was developed in consultation with community partners and is now training and educating highly qualified graduates to serve the needs of the aging community in Niagara and beyond in leadership capacities. As Dean of the Faculty of Applied Health Sciences, I'm very proud of the faculty, staff, and students in the Master of Applied Gerontology program and their commitment to the health and well-being of aging populations. The Reimagining Aging Speaker Series is another step in the evolution of our commitment to the seniors community. This is the first presentation in what will become a high-profile annual event for the Master of Applied Gerontology program that will feature renowned speakers who will delve into current issues in aging and provide ideas and analysis for practical ways forward to improve the lives and services for aging populations. These annual presentations will be of interest and relevance to all those who serve and work in the aging communities and will serve to advance knowledge and facilitate communication and understanding between academia and the broader community of seniors and all that support them. The Master of Applied Gerontology program emphasizes the application of theory and the development and implementation of the best practices in serving community needs. This speaker series has been developed to facilitate this as well. This annual event was collaboratively organized with an advisory committee of older adults and caregivers living in the Niagara region, as well as representation from local healthcare organizations, retirement homes, long-term care, community support agencies, current Master of Applied Gerontology students, and recent graduates. The committee is involved in all aspects of the event planning, including selection of topic and speakers. The intended purpose of the Master of Applied Gerontology Reimagining Aging Speaker Series is to excite and engage community members and organizations working or interested in gerontology, to support community campus partnerships, to showcase and highlight the Master of Applied Gerontology program, to engage Master of Applied Gerontology students and older adults, and to celebrate community assets. The speaker series will further facilitate community outreach and in the spirit of the late Doug Rappeljay will serve to enhance the lives of all that it reaches. Doug was very involved in the development of this lecture series and in organizing this inaugural lecture, and I'm sure that he would be very pleased with the turnout and participation we have today. I thank you all for joining this first of our annual Reimagining Aging lectures and hope that it will both inform and inspire you. Best wishes and thank you for attending.
Thank you. So my name is Elisa Grigorovich. I'm an assistant professor in the Department of Recreation and Leisure Studies in the Master of Applied Gerontology program here at Brock. And I have the distinct honor of introducing our keynote speaker, Dr. Pat Armstrong, who's a distinguished research professor emeritus of sociology at York University and a fellow of the Royal Society of Canada. Originally from Northern Ontario, Dr. Armstrong received a BA from the University of Toronto and an MA and PhD from Carleton University. Dr. Armstrong's research focuses broadly on the fields of social policy, women, work, and healthcare. And since the 1990s, she has concentrated on the conditions of work and the conditions of care in long-term care. She's a prolific researcher and has been a co-investigator and a principal investigator on many Tri-Council and internationally funded research grants. This includes a 10-year international study of promising practices in long-term residential care, a study of healthy aging in residential spaces, and most recently, several studies that explore paid and unpaid work and family engagement in COVID, and even more recently, a study in the long-term care labor force. Dr. Armstrong has published widely on gender, healthcare, and long-term care, co-authoring and co-editing such influential books as Wasting Away, The Undermining of Canadian Healthcare, Unhealthy Times, Political Economy Perspectives on Health and Care in Canada, and more recently, Troubling Care, Critical Perspectives on Research and Practices, and The Privatization of Care, The Case of Nursing Homes. In addition to this very impressive body of scholarship, Dr. Armstrong is also an advocate for care reform and has served as an expert witness in more than dozens of cases heard before different types of bodies, ranging from the federal court to the federal human rights tribunals, on issues related to women's health, care work, and pay equity. She currently serves on the Technical Committee for Long-Term Care Standards and is a board member of the Canadian Health Coalition and of the Members' Council of the Canadian Centre for Policy Alternatives. As an example of her policy advocacy for reform of long-term care in Canada, she has led the influential report, Reimagining Long-Term Residential Care in the COVID-19 Crisis. I couldn't think of anyone more inspiring to start off the Reimagining Aging Speaker Series than Dr. Pat Armstrong, the person who first introduced me to the topic of long-term care as my master's supervisor at York University all those years ago. Please join me in welcoming Dr. Pat Armstrong.
Thank you, Elisa. I'm glad you mentioned your bias in introducing me. It's always embarrassing to listen to those kinds of introductions, but I'm very pleased to be here. Thank you all for inviting me and for being here to discuss what is really a critical issue in these times, one that has been made more obviously critical by the pandemic. But there's so much to talk about, but I hope I'm leaving enough time for discussion because I really want to hear from you on these issues. We often ask children, what would you like to be when you grow up? But we seldom ask them what they would like to be when they grow old. Indeed, growing old too often seems like a dirty little secret, something to avoid thinking about or talking about. This is especially the case when it comes to long-term care. For the last dozen years or so, as Elisa said, we've been trying to reimagine ways of delivering long-term care, ways that would put life into years rather than years into life, as we heard it put in the German home that we studied. And we want to think about that in terms of both those who need and those who provide the paid and unpaid care. Well, we get positive ads about putting in those stair lifts so you can stay in your own private home, and ads showing what fun it is to be in a retirement home. We don't have any similar ones promoting the positive possibilities of nursing homes. And indeed, combined with the limited public funding and poor working conditions, all this helps explain why so many Canadian relatives feel guilty about, to use their terms, putting their mother in a nursing home, and why lots of people say they don't want to go there. I keep being sent studies that say 90% or more of people over age 65 want to stay in their own homes rather than enter a long-term care home. The numbers are probably even higher with the pandemic horror stories, I would think. But the centers don't seem to know that there are currently only spaces for less than 3% of those over age 65, and we have very long waiting lists. So in one sense, those numbers are good news for those centers. You won't get into long-term care. The same people who send me those studies often claim we warehouse, that's their term, way more people than they do in Nordic countries. But Norway and Sweden have a significantly higher proportion of their population over 65 in care homes. The share of the Canadian long-term care dollars going to what the OECD calls inpatient care is lower in Canada than in Denmark, the country often upheld for its emphasis on home care rather than on long-term care. The centers also fail to mention that many people do not have private homes, and many private homes are physically unsuitable for care, even with those chairlifts. Moreover, many homes are unsafe because older people, and older women especially, often face abuse in various forms. As the women's movement used to say, not all homes provide a haven in a heartless world. And many more who have homes face loneliness. And again, it is women who are more likely to be alone in old age. We certainly need more public and better home care, which we do see in the Nordic countries that spend much more than we do on home care. And we need to better integrate care across hospitals, primary care, home care, and long-term care. And I have to say, I started studying hospitals, took me to primary care, then to home care, and then to long-term care, perhaps going along with my old age. However, even if we provided up to 10 hours of home care of the sort that Denmark can offer, we cannot provide 24-hour public care for individuals at home. We're told it's cheaper to provide home care. But cheaper for whom and why is what we need to ask. Most often, we rely on women, unpaid and untrained for the job, frequently doing so to the detriment of their own health and their employment and their financial future. Indeed, in planning for care, we need to remember that nursing homes are mainly about care for women, by women, many of whom are racialized and/or newcomers. The media stories frequently suggest universal devastation, I should say, perhaps desperation too, in care homes. Yet, according to the Canadian Institute for Health Information, as of May 25, 2020, Newfoundland and Labrador, Prince Edward Island, New Brunswick, and the Territories had no reported deaths in retirement homes and long-term care facilities, just as the rates were horrible in Ontario and Quebec. Long-term care homes are not necessarily dangerous to your health, and we have to learn from those that did fairly well or did not do very well, like many of the for-profit homes. Unlike the stories in the media, we frequently hear positive things about care homes in our interviews and our research. Long ago, when we were living in Montreal, the man next door moved into a nursing home. He was suddenly suffering from MS and could only move his head. His wife was a nurse, and with the help of their 2 children, she'd been looking after him at home. But now those children were both leaving Montreal for work, and she was unable to handle the physical care alone. He went into a nursing home. Rather than resenting the move, he welcomed it. He had access to things like a fancy computer. He had company, and he felt safe. He'd always worried about his wife being injured as she provided care, and also that he might get injured from her providing care alone. Meanwhile, she told us she visited him every day, but she had her life back too. Knowing this story was one reason why we started searching for promising practices in long-term care, for treating all those who live in, work in, and visit in long-term care with dignity and respect. We have used multiple methods, including ethnographic studies of nursing homes in 6 different countries. We would take teams that were international and interdisciplinary into those homes over the course of a week to observe and interview, starting at 7 a.m. and staying at least until midnight. And we talk about promising rather than best practices because we're convinced that context matters and that what works well in Sweden may not work well in Canada, and what works well in St. Catharines may not work well in Attawapskat, but we can still learn from those practices. We have heard many of the same kinds of stories as our neighbors over the years as we interview families, residents, managers, staff, and volunteers. At a residents' council meeting just before the pandemic, in a home that was crowded and old, we asked if there was anything better here in this home than living in their private home. They were unanimous in saying yes, somewhat to our surprise. Asked to explain why, they said, we have company, we feel safe, and we have activities. One woman said, people think we spend too much time watching TV, but if I was at home, that's all I would do, and I would not really eat, have clean clothes, or a clean house. Of course, none of this is to ignore the need for major reforms in home care and long-term care, or to ignore the devastation that has happened in long-term care during COVID. Nor is it to suggest that we cannot learn from those other countries and other places. Indeed, we have to ask why pre-COVID surveys found that a majority of those in Sweden would prefer residential care to home care if they need help more than twice daily. And this is the case even with their generous home care services. We can learn from that. The multitude of studies and commissions have found plenty of issues that need to be addressed, as we showed in the report Lisa mentioned, Restoring Trust, our 2020 study for the Royal Society. At the same time, there's been a search for one right way, for a perfect model that will address all of these issues. Now, there are plenty of models out there. And after the Toronto Star had a series that praised the butterfly model, which now has a new name, but in any case, it was then called the butterfly model, the city asked us to look at their 10 homes and at the models to assess which, if any of them, would work in the Toronto homes. Now, we had already spent considerable time studying a British home that was an early adapter of the butterfly model, and we had studied in homes with other models, such as the Eden alternative. Now, while there are variations among these culture change models, they share 4 basic principles. The first principle is, to the degree possible, residents should direct the care they receive and be involved in activities. Often called resident-focused care here, we would add that such care requires attending to the working conditions because, as Elisa said in the introduction, we are firmly convinced that the conditions of work are the conditions of care. This principle is very much related to the second one in these models, namely that there should be a focus on flattened hierarchies, on teamwork, on more autonomy, flexibility, and support for staff, on participatory decision-making, and an emphasis on continuity of care to foster relationships amongst residents, families, and staff, and more training. We hear that a lot. This means, we would say, that there has to be enough staff, and enough staff with the time, the knowledge, and the autonomy to respond to individual needs. It means providing decent pay and benefits that recognize the skill, effort, responsibility, and working conditions involved in this work traditionally done by women, and still very much done by women. It requires continuity in care, which means mainly full-time staff and all services provided in the home. And we would add, it requires all staff to be part of the team, recognizing that housekeeping, laundry, dietary, and security are critical to care, as we saw in Nordic countries. And we wrote a book called Wash, Wear, and Care, precisely because we saw how important clothes and laundry are to dignity and respect in long-term care. According to the Ontario Staffing Study, less than half the direct care workers are full-time, and we don't even know how many of those other services are contracted to temporary workers. In our research team meetings over the last 2 days, we heard that the research indicating better outcomes during COVID for the greenhouse model, for example, also found that all of their services were provided in-house, which perhaps goes a long way to explaining their resistance to COVID. The third principle that these models share is the call for a home-like atmosphere based on small units and allowing residents access to things like fridges and gardens. There are really two principles here. One is about size, and that is small, and the other is about home-like. And our team has debated these principles at length over the now 15 years we've been working together. Our Nordic colleagues were shocked at our 32-unit households in Ontario, but they started at the same time to think that their units, that could be from 6 to 8, were too small and were often too boring and too limited. Moreover, small homes are much more limited in terms of the services and flexibility for staff and harder to locate in urban communities. Now, we continued our debate in the last 2 days, the debate that, as I said, started a decade ago. And we agreed that there was no perfect size, although we should avoid too large or too small. And we should take residents, family, and staff into account in determining size. We should also think of what we talked about this week as bringing the outside in and the inside out, about locating homes where people live or have lived, and encouraging communities to come in and residents to go out. This also means thinking about transportation and what you can see out the window. Grass growing is boring for a while, after a while, and many residents told us they didn't want to be put out to pasture. And we encountered homes in the Nordic countries where half of the floors were occupied by students, and of course, very commonly lots of childcare, but much more intergenerational integration into those homes, which give them a feeling of life that is really important, I think, that we think as a research team. Home-like is similarly complicated because it leaves aside the question of whose home is the model. Some of us love the hardwood floors and bright colors we saw in Sweden, while others love the muted tones, the old furniture, and the carpets we saw in Canada. Moreover, the focus on home-like fails to encourage thinking about the positive aspects of congregate care. One man who was in a 4-bedroom in Canada said he loved it because it reminded him of living in a kibbutz. Instead of constantly trying to recreate some idealized notion of private single-family homes, why aren't we thinking about new ways of living together and making that living worthwhile? So let me move on to the fourth and final principle that comes out of these models, namely that the leadership should focus on continuous quality improvement. The need for such leadership has been made particularly obvious by the pandemic, and we would argue that contracting out leadership to for-profit firms, as is happening in Ontario, can undermine that kind of continuity in leadership. Based on this research that we did with the Toronto Homes and that we've done in 6 countries throughout the world, we would say that there's much to be learned from these models. However, there's no single perfect one. As we've heard many times, one size does not fit all, especially in our major urban centers with their diverse communities. So where do we go and what do we do? I think we have lots of indicators. As I'm sure many of you know, and as Elisa mentioned, the Technical Committee of the Health Standards Association has come up with somewhat different principles from those in the models in their proposed standards. And again, I should say that I am in a bit of a conflict of interest because I've been part of their development, although of course it's very much a committee product. The committee identified 6 overarching foundational principles to guide and inform the development of the standard. They all raise questions, I think, for further discussions, which will take me to the end of this presentation. First, long-term care homes are both homes and workplaces where the conditions of work are the conditions of care. I am quoting here from the standards. A healthy and competent workforce is key to creating a home-like environment and delivering high-quality resident-centered care. However, here too, home-like is not defined. Second, the standards say homes should provide high-quality resident-centered care focused on adopting resident perspectives to meet the individual needs and preferences of each long-term care resident with a supportive and relational approach. Again, we would add that that requires continuity in the staff and power for the staff. The third point is that provision of high-quality resident-centered care is evidence-informed, enables equity, diversity, inclusion, and cultural safety, and addresses systemic racism. None of those factors, I would add, have been raised in the cultural models cultural change models we've studied. The fourth of the 6 points in the health standards are the right to long-term care residents to choose to live at risk is respected. And I think this is really important, especially when it does not negatively impact the safety of other long-term care residents or the workforce. I think this principle is particularly noteworthy because unlike the models, there's recognition in the proposed standards of at least one major tension, that between safety and risk. As we explore in our small book on negotiating tensions, there are many more tensions, such as that between social and medical care, between the rights of workers and those of residents and families, and between residents' preferences and their families' preferences even. Tensions that need to be recognized as continuing and continually needing strategies to address them. The fifth of the 6 principles that begin the health standards are improving the provision of high quality resident-centered care in long-term care homes requires continuous data collection and monitoring. And we don't have very good data on our long-term care homes in Canada. And finally, federal, provincial, and territorial legislation, regulations, and accountability mechanisms related to the provision of long-term care are needed to enable the achievement of these new national standards of long-term care. The 6th point is not so much a principle as a recognition that standards or models require legislation and funding tied to meeting standards. I would say this is especially the case around minimum staffing levels, training, full-time employment, crowding, and ownership. Also missing is the means to ensure public accountability and a national, provincial, territorial labor force strategy. Moreover, neither the models nor the standards address the question of access in the sense of how many spaces will be provided at what costs, nor do they specify the range of services provided through public means. So in sum, we have some very good evidence and some very good ideas to guide us in designing long-term care that works for all those who live in, work in, and visit in long-term residential care. What we need is the political will to implement them. And we have an opportunity with an election right now to demand the kind of change required. So I look forward to hearing from you on what's missing from what I've said, what is useful, and what we can do together to bring about some of these important changes. Thank you very much.
Thank you so much, Dr. Armstrong, for sharing that wealth of knowledge that you've brought to us today. I welcome everybody to either put your questions in the chat, or if you do feel comfortable, you can raise your hand and turn on your camera, and you can ask your question to everybody here today. Looking forward to hearing everybody's wonderful questions and starting the discussion.
I should say I cut what I had to say in half because I really want to hear from you.
I can start with a question that we did have from our advisory committee if you'd like, and that would be, if you could magically cancel out any current practice in long-term care or magically introduce a new practice, what would that be and why?
I would make sure that no services are contracted out. I think we often forget that when we talk about this is a home, and everybody talks about this is a home, this is a home. Well, you know, you cook your meals in your home, you do your laundry in your home, you do all those things in your home. And we forget about food, for instance, that what makes you want to eat? It's the smell of food cooking. What makes you want to eat is having the time to be able to go, not when food gets contracted out, they deliver it for a specific time and then the plates have to be taken away at a specific time. And the same thing about laundry. We really, it's interesting to me. We went to a board meeting in Manitoba at a big long-term care home, and they were asking us what we had found and if we had any questions. And we raised the question of laundry, and the CEO said, "Oh, let's go on to more important things." And the two family members who were on the board said, "No, stop. Laundry is really important." I can't tell you how many times we heard about mother's lost sweater. And that seems trivial to some people, but that sweater was her sense of identity, the piece she brought from home, the part that makes her life worth living is feeling this is her and this is her important to who she is. And thinking about making sure you do that in a home. In Sweden, we were in residences where there was one of those European style combination washer dryer in every room. And that's where your personal clothes were done. And of course, it also limited infection rates spreading to other places because your clothes stayed in the room. But the care worker would come in the morning and put on a wash, take her 3 minutes to put it in. And then if there was stuff that would shrink or get wrecked, she just hung it up another 5 minutes afterwards. And that made such a difference to the people who were living there. So I would really focus on those things that we don't think about as care and make them really central to living in long-term care. That's really where I would start. Although the question reminds me, we end up every interview we end up by saying, if you were in charge, what would you change? The answer I got to this question in a big Norwegian home where I interviewed a woman who was relatively recently named as the head of human resources. She said, well, if I was in charge of Norway, I would pay the women who work here what we pay the men on the oil rigs, because these women work harder. And that's another thing I do. It's just the start of my list. I can't hear you, Kate, I'm afraid.
So I do see Janet has her hand up, and then we can move to the questions in the chat. So Janet, if you click the little mute button, it should unmute you so that you can ask your question.
Oh, I think I'm already unmuted. Can everybody hear me? Would be my first question. Great. Dr. Pat Armstrong, thank you so much for that presentation. Really enjoyed it. I think something that anybody on this platform doesn't know about me, I worked in a nursing home for nearly 6 years in the States. I was one of those people who administered medication for that long. And one thing I vowed was I would never want to live in a nursing home. I tell that to my kids every single day. One of the things I really wanted to ask from the perspective of newcomers, what are some of the things that could be rolled in so that newcomers are feeling comfortable? Because I come from a country where we don't have that many long-term cares or assistant homes or anything of that sort. We really truly believe in looking after our own as families. So what are some of the things that could be incorporated within the long-term care to accommodate new immigrants?
I think you've raised a bunch of different points. I think to go back to something I said earlier, a survey in Sweden showed that the majority want to go into a long-term care home. So the question is, how do we make those homes places where people want to be? The other thing I would say is, I don't know what country you're talking about, but I would say that our former president at York's, when we got this grant and we were invited to breakfast to celebrate this grant, he said, in my country, Egypt, we don't have any of these kinds of homes. And yet we had on our team a researcher who had studied long-term care homes in his country. I think we often have more of them than we think in various places. And I think that if we want to make these places where people want to be, and I mean that not just in terms of where you would like to live, but also where you would like to work, we have to think of the whole place, and we have to think about both parts of that. Because if the people who work there don't have the conditions to provide them with the kind of care that is required, and if they don't have the kinds of access to the education that they need to provide that, then it's very, very hard to provide good care and to feel satisfied in your work. And right now in Ontario, we are relying increasingly on racialized and our newcomers in Canada. And certainly I think that there's no question about the right to work in this care place. But if we're doing this as a kind of a way of avoiding improving the working conditions and relying on people who have no other choice, then it's not working for anybody. And so we have to make sure that we are really seriously thinking about the conditions. And before this meeting started, we were talking about the question of violence. We did a survey before I started this big project. We did a survey in the Nordic countries and in Canada of people who work in long-term care. And one of the really startling differences is that the workers in Canada in long-term care were more than 6 times as likely to say they faced violence on a daily basis. And in the resident population in both countries is quite similar in terms of the proportion with dementia and behaviors, etc. The main differences were the staffing levels that were more than 3 times as high, and in the autonomy and teamwork that allowed the staff to work together, to learn together, to figure out how to prevent those kinds of behaviors. And so the best way we can support the newcomers in the labor force is through the conditions and supports for education. I'm sorry, does that mean someone's objecting to me?
No, I think I cannot unmute my button, and you'd ask where I am originally from. I'm from Zimbabwe originally, and I cannot seem to unmute myself. I'm so sorry.
It's okay. All right, we do have some questions in the chat. As long as, Janet, you don't have any follow-up questions that you would like to ask Dr. Armstrong.
No, I'm okay. Thank you so much, Dr. Armstrong.
You're welcome.
So we have an observation from Gail, and she says, my mom has been in a not-for-profit long-term care home for 6 years. The staff are caring and the home is clean, but it is not enough. The home is institutional in both look and feel. The staffing levels are too low for personal care. I am horrified by the number of residents who sit in the corridors or in their room for long periods of time with nothing to do. There is not enough activities, especially in the evenings or on weekends, and not enough access to outdoors, especially for those who have mobility issues. Long-term care residents do not live Monday to Friday 9 to 5. There is no joy in mealtimes. It is rushed, and there is not enough fresh fruit and vegetables. Improving all of these issues comes down to funding and commitment to change at all levels.
I couldn't agree more. There's just so much the staff can do, and the numbers are important. And as I said, it's not only numbers, it's also time. But it's also our whole, we understand accountability as counting tasks. And we think that the only thing that counts is what can be counted. And what can be counted are very specific kinds of tasks. Did you get your medication? Were you in your seat on time? Did you have a bowel movement? And, you know, to quote the person asking the question, that's not about joy. It's not even about living. And we did a study published as It Is a Scandal. And we looked at when scandals happened in nursing homes in the countries in our project, what was the main result? And now, of course, they all had investigations and did stuff. The main result in North America was more regulation. But those regulations tend to focus on the worker and not on the funding and the overall structure of the place and on the working conditions. And that didn't do anything to bring joy to anybody. It just meant that you spent more time writing stuff down. And in the end, it doesn't really make people accountable. So accountability becomes counting. You do more counting. You think that this is actually going to improve care. What it has primarily done, we would argue, is take time away from care and take autonomy away from the staff in order for them to actually attend to the joy part of the work. And in terms of the not going outside, as the question included, we've seen this in so many places where there had been beautiful places to go outside. Oh, but we can't go outside because somebody might fall. We don't have someone to go out with them, so we don't know if they might trip. And if they trip and they fall, that's a big bad mark against us. And falling is terrible, so we're better to lock the door and keep everybody inside. We do the same in terms of falls are just the worst thing that can happen. So when we bring people into nursing homes, more and more we put them in a wheelchair because then their risk of falling is reduced. I sat in a Norwegian home watching what they call an occupational therapist working with a man, really pushing him to walk, really encourage him to walk. And it was interesting to watch. It was clearly really hard for him to do this. But also it was so interesting to watch the pleasure he got from actually being able to walk. And I said when I was interviewing this therapist afterwards, I said, "Aren't you afraid he's going to fall?" And she said, "No, we have to take risks. We have to encourage them to go to the full extent of his capacities." And so I said, "Well, what happens if somebody falls, because then you have to write it up and there's a big issue and and they said, "Well, we have a meeting and we talk about, could it be avoided? Was it a problem? Was that a mistake that we can avoid in the future? Or is that just something that happens?" And she said, "We don't even have a meeting if nothing happens as a result." Whereas we do in Ontario, we go and write it down. If you fell no matter what, even if you hop up and walk down the hall. So I'm not saying there should not be regulations. I want to be really clear about that. But we have to have regulations that are about making life worth living and not only about what is the safest thing you can do, because safe is boring if that is your only focus. And so we see lots of balconies locked up because someone said, "Oh, we heard that somebody 5 years ago fell off a balcony, so we've got to keep the balcony locked." And that's why I'm so excited about that section in the proposed standards that says you got to balance safety and risk. So all of those things are necessary. Another really, really important question is the continuity in care. as I'm sure everybody on this call knows, that especially with people who have some form of dementia, continuity is really important. If you have the majority of your staff part-time, and then you of the care staff part-time, and if you have a whole lot of other people coming in, dietary, cleaning, blah, 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 you have no continuity of care. But it's not just about, in those terms, about the resident, it's also about the staff. They tell us it takes us so much more work when we have a whole bunch of part-time people coming in. They don't know where the equipment is. They don't know how it works. They don't know Mrs. Jones hates peas and she'll spit them at you. You know, you just got to give her peaches. You know, like, so it takes them so much more work if you don't do that continuity. And we were in a home in BC, one of the homes we studied in BC. They had contracted out their food services. There was a big sign in the dining room saying, "Don't talk to the dietary workers." And in other places we've been in, the dietary workers are the people who chat, who bring that joy to the eating experience, you know. And eating's the main event of the day, just like it is on a cruise ship, you know. Like it's the big thing that happens. So why aren't we thinking about making that as pleasurable as possible? I'm going on and on. I'll give you one more example in this case. When in a home the butterfly home actually that we were in the UK, that they had their own chef, and he was really interested in trying to figure out how to help people eat. And he said, you know, we give them a full plate. They take one look at it. It's way too much fun, and they don't eat anything. We're taking, all my food was coming back on the plate, or a lot of the food was coming back on the plate. So he said, I decided to make the food in little pieces and serve it like hors d'oeuvres. Go around and serve. And the amount of people gained weight as a result of, you know, being able to eat in little pieces, not having, and you know, and if there's one thing on the plate you ate, then you're not going to eat any of it. Another thing they did in this, they had another person who had problems with an eating disorder all her life, was not interested in eating. They would leave food around for her in different places, and she gained weight because then she could eat when she felt like it, as opposed to, and there was another woman who came into this home who had always had a gin and tonic first thing in the morning. So they said, fine, she can have her gin and tonic first thing in the morning. And if she wanted it later, they gave it to her again, but the gin got less and less, and the tonic got more and more as the day went on.
That's great. And the more examples you give us, the better, because these are the things that bring us joy on the call, I think, looking at everyone's faces during the examples. The next question is from Stephanie. She says, there is a real staffing shortage in the sector right now. Do you have any insight from the other countries on whether they have this issue as well? Using outside agencies compromise the ability to execute on resident-centered care?
I certainly agree on the agency bit. And in fact, we spent a great deal of time yesterday talking about exactly these issues. And I should have said that in our meeting yesterday, we had people from Norway and Sweden and Canada. We didn't have anybody from the UK. Well, yes, we had someone from the US. Charlene Harrington was part of that discussion. And they're having the same problems in Sweden as we are having in Canada in terms of a shortage, in part because they've been going in the same kind of direction we have been. They have been reducing the staffing levels. They have been reducing the number of full-time jobs. They have been introducing some agency work. And there's no question that that undermines care. Now, in the pandemic, we got very concerned about the fact that people who were working part-time were actually working full-time, but part-time in various places. And that we became concerned about traveling infections in terms of working in more than one place. And we cut back a bit on that in the time. There are some of these practices that need to be continued. We need to be making sure that those people have the opportunity for full-time employment in one place. But of course, why were they working in more than one place? They were working in more than one place because they couldn't earn enough in one place. Why do people take agency jobs? They take agency jobs in part because they get to have some control over their schedule. So in Norway, they're starting to develop a strategy to allow staff to have more control over things like weekends and nights and the distribution of that labor and how you figure that out so that that people can fit the rest of their life into their work life in a more reasonable way without there being and doing that as a result of some kind of discussion. So the question is there a shortage around the world? Yes, there's although Charlene Harrington from the US was saying that one of the things that's happening during COVID is that they now have a lot of empty spaces in long-term care homes because people aren't there and they don't have any staff. So we have to recognize that unless we change the working conditions, which is, as I've been saying too many times, is about more than money, but it's certainly about money, and it's about benefits. And we have to make it valued labor, and that's about more than money. It's about giving you some autonomy and some rights. Sorry about the phone.
The next question is, Dr. Armstrong, thank you for sharing your knowledge and insight. I think we all agree with that. I wonder if we could comment on the resident admission process and welcoming process. I feel we are falling short. Have you seen a model that really allows a resident-centered experience, both on day one and ongoing?
Interesting question. As I said, we were meeting in the last 2 days, and one of the things we were meeting around, we've got a book that we're just finalizing on unpaid care. And one of the chapters is about the transition into a nursing home and what that process is like. Actually, I think one of the best examples we saw of the admission process itself was in Ottawa, where they send someone or maybe two people into the home when they're preparing someone to come into long-term care to have a whole discussion about what happens in long-term care, what you can expect to do. One of the other chapters in this book is about how there's that very few of the documents that you receive from long-term care tell you what families can and can't do. A very few of them tell you how you can participate or the limits on your participation. And there are really different policies across Canada in those terms. Who can visit, when you can visit, whether you can help them brush your teeth, what you can bring in with you. And we've heard so many complaints about you, especially in Ontario, where you get 24 hours notice. You go into long-term care. They have all of these questions about, you know, how do you want to die with dignity when you're going through this massive change in your life, that we really need to focus on this. And this home in Ottawa that did give a lot of thought to how you do this process by preparing people before they came in and then having someone assigned to a day to introduce the family and the new resident into the home so that they could make a transition smoothly. Now, the other part of this, and that may be part of this question, is just figuring out how you apply to go in and what you need to do to go in and how you go through that process. And with these new care teams, even I don't understand how you do that in Ontario right now. It's gotten more and more complicated and difficult for what is a really, especially in this country, seen as a major life transforming move. And it's interesting, it's seen much less as that in the Nordic countries. And to go back to that survey, the people moving into the home are much more interested in moving into the home, and the family feels very positive about the move. And part of that is that whole process, the preparation, the admission, understanding who gets to do what, when, and how it works. And another part of it, I should say, is having the most responsible nurse. All nurses are responsible, I think, but in the sense there's a named person that you can go to who will answer your questions, not just on the before, during, and after, but during the whole process, after you move in on a daily basis. If you have some kind of issue, some kind of problem, that there's one name you can ask, and a person who will find out the answers for you. I don't know if that answers your question, but do we have a perfect system? No, but some are better than ours.
Yeah. The next question comes from Peter. Hello, Dad. Thanks for coming. Dr. Armstrong, would you have had any thoughts or advice as to how to engage with the younger community to seek to dedicate their career to working in a long-term care environment?
That's a really interesting question. I was contacted by a student who, during COVID, needed a project. And I said, this should be her project. She could figure out, she should think about how can we get younger people thinking about long-term care. One of the problems is that there are very few, when an RN and an RPN is going through their education process, they spend very little time in long-term care. It also has a really, as one of our earlier questioners said, they have a very bad rep, so people want to stay away from it. We did a study for the Ontario Nurses Association where we interviewed RNs and RPNs about long-term care. And there's a wonderful quote in there from an RN who said she wanted to do pediatric nursing. She'd worked in a hospital and she got laid off in the cutbacks. And her father convinced her to apply to a long-term care home near where she grew up. And she only did it very reluctantly. She said, all my friends said, oh, you're going to lose your skills. You know, they're terrible places to work. You don't want to go there. And she said, I love my job. And I use the entire range of my skills. And she did this long description of it. She said, in the hospital, I was using a much narrower range of my skills, and I was using those over again. I could be asked to do anything here, she said. And it's a challenge, but it also makes it interesting. And I get to know my residents and their families in a way I never did in the hospital, because, you know, it's at the least possible time when you're in the hospital. Sometimes you don't even remember their name from one minute to the next. Whereas this is the opportunity to really get to know people and to feel the satisfaction of helping people, of bringing some joy sometimes. So, I mean, of course, one of the ways to bring more people in is to make the conditions better. But the other is to expose them more and to think more about those homes. I have certainly been in homes where I would be prepared to go. So, you know, they're, at least when they're in the days when there were more staff.
Just being mindful of the time, I'm just going to scroll through. There's one question is pertaining to the transition to long-term care. I'm just going to look, there is a story here. Just seeing the question within this paragraph. So with appropriate COVID testing and isolation of 10 days. So I guess they're wondering about the policy regarding COVID and having individuals isolated for 10 days as they wait for their room. And Elisa has her hand up. I'm not sure if it's about this question. No? Okay. So yeah, just your question around these policies throughout COVID and long-term care.
I can't say that I'm a big expert on infection control. I would recommend to people, the Science Table has just come out with a paper that's called COVID-19 Pandemic's Impact on Long-Term Care Homes, 5 Lessons Learned. It's a subtable of the Science Table. It's about congregate care that I also serve on. And one of the things that's talked about, and there's 2 kinds of questions, I think, involved in the question as you reported it. And one is to ensure that residents have access to timely and or so that they have in-person access to relatives and broadly defined and friends, and access to other people. And that 10-day period means that you don't have access to other people and can be very lonely. And I think that there's a lot of rethinking going on about how you can make that contact safely, not just through electronic communications, but also through some person. Now, often the physical structure of the place makes that really difficult. If you're in a 4-person room and there aren't other places where you could have contact with people properly protected, that makes it more difficult. But there's certainly, what we say in this paper is we have to figure out how to do that. Because one of the other things we did in that Congregate Care Committee is look at what happened to people who had no friends and relatives listed on their care plan when they came in, and they were more likely to die, even though they had they came in with less complicated health diagnosis. So loneliness is a health risk, and we have to figure out. And I mean, one of the issues about the pandemic, of course, is that we've been learning about how it spreads. We've been learning about how the protections are, and sometimes at the cost of people's health, not in the sense of them catching COVID, but in the sense of them being isolated and alone. So I think that there is increasing recognition that we have to be careful about the forms of isolation and how we do that while still keeping not just that individuals from spreading it, but spreading it in terms of the safety of other people, which takes us back to the safety risk question. So I think my answer is it's complicated. I'm not an expert on infection control, but that I think that we are now attending to the question of how can we attend to the question of the importance of human contact and what we often call social support.
Sounds good. And for the person who asked the question, Gail did respond to this individual by saying that they have hired companions as well, who can spend time with individuals. And currently at present time, you're limited to 4 caregivers per resident. So hopefully that helps answer the question too around individuals who are isolated.
Well, and the rules have been consistently changing, and you try, the families in COVID study we're doing, we've been working with family councils, and one of the things they complained about was the rules are different in every home. So you don't quite know what you can and can't do. Now, there could be benefits to that variety, you know, but on the other hand, if you can't find out and you can't figure out what the process is, or you can't, and the rules are constantly changing. So it's a problem.
Absolutely. A question that Gail has is there a group that we can join that advocates for changes within long-term care?
Yes, the Ontario Health Coalition has put a lot of focus on long-term care. The Canadian Health Coalition as well, and and the Ontario Health Coalition has regional parts to it, so you can join a local group of the Ontario Health Coalition. My bias, my husband's on the board, so you should just so you know where And the Canadian Health Coalition, also, as Elisa mentioned, I think I'm on the board of the Canadian Health Coalition. But there's also Care Watch, which is much more interested in home care than they are in long-term care, but they do some of the work. And other organizations that haven't been set up to look at long-term care has become increasingly interested. I've done a lot of talking with university women's clubs, for instance, or there are a lot of seniors organizations, or every home is required to have in Ontario is required to have residents part of the family council. But if you have someone in a home, I would really say get involved in the family council. So I think that there are a range of possibilities. The Ontario Health Coalition has been doing some very, very good work on this, I think.
Elisa, I see you have your hand raised. Would you like to ask a question?
Thank you, Kate. I do. So one of the standards that you mentioned around the dignity of risk and how to balance it. So I'm wondering I think that this can be hard to imagine. So I'm wondering if you can give an example of like a promising practice example of where dignity of risk has been respected. And what do you think would be needed to actually respect dignity of risk in practice in our context?
Well, my example from Norway with the occupational therapist is about taking a risk of falling, right? I think my example from the UK with the risk of having alcohol, it is, I would also say the risk of unlocking those doors to outside. In a home we were in this was my favorite home, actually. It was in Norway, where in Norway, by the way, they're all private room, virtually all private rooms with their own bathrooms, and often with their own sink and like a little kitchenette almost. And in this home, everyone had a sliding patio door out onto an enclosed yard. It was a huge yard, but you could go out whenever you wanted. And you know, sometimes people fell when they were out in the yard, but being able to go out in the yard brought a lot of joy. Or out it was quite a large area, actually. The other thing about this home was that it was physically built into a town complex that had the town swimming pool, the town cinema, had a spa, it had a daycare center and a climbing wall and a cafeteria, all in one building. And so they said that the residents, they had a phrase in Norwegian, which of course I can't say, beyond muta, I can't say anything in Norwegian. But that was, they could go anywhere without putting their shoes on. Basically, you know, it was like being in your own home, in your own village. Now, you know, we would lock the door, right? So those are just, I think, some examples. Just sometimes people get in trouble, yes, but the life without risk, as I said earlier, is really boring, you know, if we wanted to be. But on the other hand, what we see is without risk, you know, spend your day in bed, well, you'll get bed sores, you know, like there's a risk to many of the things that we see as safe, like giving people antipsychotic drugs, you know, to keep them safe. I think marijuana, we did a workshop for nurses that we called Sex, Drugs, and Rock and Roll. And they talked a lot about the use of marijuana and how they're finding it way more effective than in terms of helping people sleep or relax, but it's often understood by families as a risk, you know. So there's a whole range of them, Elisa, that are.
Thank
I
you.
see Dr. Gardner has a question as well. And just being mindful of the time, we'll go to Dr. Gardner, and then there's one more question in the chat.
Thanks, Kate, and thanks, Pat. This is just an amazing conversation. I agree with Kate. Your stories and examples really animate what it is that you're speaking about in such a beautiful way. I'm sure, like everybody, my mind is just flying around in 100 different directions. But I want to keep thinking about design and thinking about designing for joy versus designing for safety. And you've spoken a little bit about architectural design, which if you have other examples or sort of promising practices in terms of how to do design from an architectural perspective, but I'm also thinking about assisted devices in terms of design. And I don't know, I agree with you about falls, and I'm thinking like falls in and of itself. Like instead of falls, can we think about how to keep residents bouncing? And so there's a project I'm working on about hip protectors. And so rather than keep people from moving, it's almost like a harm reduction approach to keeping people moving in spaces by like, what tools and equipment? And then of course, how do we make that sexy rather than sick looking? But I don't know if you've seen anything about that, or if you just comment a bit about design and designing for joy and the promise of that.
I think I mentioned tensions. We have 4 small books we call bookettes that you can download without cost from the Canadian Centre for Policy Alternatives. One of them is called Physical Environments in Long-Term Care, where we try and take up some of these questions. One of them is the question about location that I was raising briefly in my talk. We think it's safe if we put people out in the country where, you know, it's boring if there's nothing happening. And one of the examples we were given yesterday was at home in Norway, where there was a construction project outside, and the community got upset because, you know, it was going to disturb the residents. And the residents said, "Are you crazy? It's way more interesting watching the construction happening." So the outside is important. I think the location, transport, all of those kinds of things. But inside, there are so many questions. Locks on doors. Do you have locks on doors? You know, can you lock your door? We have been in homes where you could lock your door. What about sounds? You know, are there bells ringing all? If you do as a protective device, those beds that make that make a noise when someone's at risk, that might protect that person, but the sound in the place is pretty joyless. It's like your microwave going off all the time, right? When my husband leaves his coffee in there. And so we talk about sounds, we talk about smells, we talk about but also about, in terms of I think that it's really interesting about what kind of safety, personal protection can you have that that is acceptable and doesn't make you look dumb. Well, you know, we managed to get kids to wear helmets, right? And the woman is a physician, lives next door to us, who's a 5-year-old, went back to school, and I asked if she wore a mask, and she said, yeah, she wanted to wear a mask because she feels undressed without it. You know, like, so making that stuff a whole lot of stuff has become acceptable for if you were an athlete. Why isn't it acceptable if you're older, right? Like, why is it a signal of weakness if you're my age, and a symbol of strength if you're 20? So, I mean, part of it, I think, is getting over that. But I also think about the design of furniture. We've been in homes where there aren't any arms on the chairs, but, you know, which is just stupid. Or bathrooms where the toilet's shoved in the corner, which is equally stupid. Because you can't even get your walker around it, let alone people help you do a lift, right? And so little attention is, or also thinking of workers. And again, we really insist on, you have to think about the staff as well as those lifts that they have to push on carpets down the hallway really wreck their backs, right? There are so many of those things. Or in a home we were in, they thought they were being safe, the architects designing the medicine cabinets up high, but then the short women who were working there couldn't reach, had to bring on stools, you know. So anyway, those are some of my ideas.
Just being mindful of the time, I see there was 2 questions in the chat, but I do want to hand it over to Sherry Davis, who is our wonderful psychogeriatric consultant at the Alzheimer's Society, just to say a few words of thanks to Dr. Armstrong for coming with us today and everyone who attended our session today.
Wow, well, I think my feelings are going to resonate with others as well, that I'm feeling very inspired, and it's really my honor on behalf of all the participants and the members of our planning committee. I'd like to sincerely thank you, Dr. Armstrong, for not only joining us today, but for really sharing with us your engaging and inspiring presentation this morning, and especially having this Q&A opportunity to really pick your brain and talk about concrete ideas. A couple of things that really resonated with me just quickly was hearing, you know, this resident or person-directed care. I love the idea of having a person's voice heard, but also listened to. And I want to hear, what is the risk that's more important to you, so that you're living the quality of life. Hearing about the integrated care teams and how conditions of work really equate to conditions of care. Again, I think it's that amazing concept to be able to think about our home and what does home look like for individuals is a beautiful concept, and perhaps we can offer unique opportunities for the unique people that make up our communities is a beautiful thought. And again, that continuous leadership and growth, being willing to be vulnerable and to take risks as a leadership team and as care partners in our community. I want to thank everyone here for attending today, and thank you for taking the time to participate, for being change makers, really, because as together, as we reimagine the experience of aging and what we are looking for as individuals, this topic of aging obviously touches each and every one of our lives, and change and innovation starts with a conversation, as we had today. It grows when our community becomes aware and we have these shared ideas for change. And finally, it does come to fruition when even small steps are taken to improve the experience of older adults and their community members. And so thank you again, Dr. Armstrong, for sharing your research, your ideas for us as community members who can make a difference in the lives and the lived experience of older adults. I would also like to thank Dr. Polly Gardner, Dr. Elisa Grigorovich, Tracy Shank, and Catherine Scully, who are members of the Brock University faculty who really initiated and were the driving force behind this inaugural event of the Master of Applied Gerontology Speaker Series. And a very, very special thank you to all the volunteer members of the MAG Reimagining Aging Speaker Series Advisory Committee for all of your collaborative work, your insights and dedication, all of which has made this event possible.
Thank you, Sherry. That was wonderful. I wanted, before we officially close, to just give a moment to Dr. Armstrong to close the session and perhaps share kind of one takeaway or one insight that she has for us before we wrap up.
I would say we all have a vested interest in long-term care. That's my final word. Thank you all. I really enjoyed this session.
Thank you all for coming, and thank you so much, Dr. Armstrong, and to all of the participants on the call. I wanted to just let you know that if you register, you will also receive a survey, and for your feedback about our session. And also to please stay tuned for the next session, which will be happening next year in the speaker series. Thank you and have a wonderful, wonderful day.
Bye.
Thanks, everybody. Let's unmute everybody.
My second meeting, and they're long meetings. 1.5 hours each. 3 hours gone.
Everybody's unmuted.
We might want to mute just again, because I think some people don't know that they're unmuted. They've walked.
Not sure who's still here.
Kate, we can stop recording.